We are moving on to our next session. We welcome Dr. John Peter, Senior Physician, Maria Hospital, Adoor, Dr. MANIMARAN, General Practitioner and Secretary, IMA Pandalam, to chair our next session by Dr. DEEPAK D, Insulin in Primary Care, One Size Doesn't Fit All.
So very good morning to all. First of all, I thank Dr. Prashant Shankar for inviting us to chair this session. Our next topic is about insulin in primary care. One size doesn't fit all. It's an interesting topic. We know that insulin was discovered in 1922 by Banting. After the discovery of the insulin, the treatment of diabetes has been revolutionized by the treatment of insulin. Various types of insulins are there since then, but we don't know which type of insulin, whether to start initiation of treatment. There is a confusion among our doctors, especially in the primary care, when to start, which type of insulin to start. So Dr. DEEPAK will give you an interesting topic about, and he will clarify our doubts in this 15-30 minutes. Thank you to Dr.
Dr. DEEPAK. He has completed his MBBS and MD at LIP Medical College, finished a diploma and a master's in diabetology from Annamalai University. Now he is working as a consultant physician and a diabetologist for the past 10 years at Sanjivani Multi-Speciality Hospital, Kollakadavu, Chenganur. I invite Dr. DEEPAK.
Thank you, Chairperson.
Thanks.
At the outset, let me thank Dr. Prashant Shankar and his team for inviting me. And this is a new thing that the PADMA, the Alliance for Sharing the Knowledge of Medicine, Diabetes and the Allied Specialties. And to go green is another concept put forward by Dr. Prashant Shankar. And we are actually very much overwhelmed by the presence of the audience as well as the ambience Dr. Prashant has arranged. And let me go to the topic proper. The insulin in primary care, one size doesn't fit all. As Dr. Prashant has mentioned, the burden of diabetes is increasing. We know about 35 million people in India with diabetes, they were unaware of their diabetic status. And among the diagnosed patients, only 30% are actually controlled. And the more sad thing with this is that of the 90% that who were unaware of the diabetes, they assume that the diabetes is under control. This is a South Indian study which states that about 19% of diabetic patients in India are in good glycemic control as per the HbA1c target. But our average HbA1c target in India is about 2% higher than the standard ADA guidelines. So for optimizing glycemic control, we know both the fasting as well as the postprandial sugars must be controlled. So let me explain the famous Monier's graph, in which we know that the HbA1c level, if it is less than 8.5, the major contribution is from the postprandial sugar, while if the HbA1c is more than 8.5, the major contribution is by the fasting sugars. But there is a slight difference in the HbA1c paradox condition in India. The major thing is that we have similar contribution of postprandial sugars if the HbA1c is less than 8.5. But when the HbA1c is more than 8.5 also, we have similar postprandial glycemia in Indian patients. Why the paradox? It's mainly because we have a high carbohydrate intake in our diet and the lack of exercise that contributes to higher postprandial glucose excursion. The postprandial target recommendations by the various governing bodies, it varies, but as of now, the ADA and EASD, they have the consensus of 1 to 2 hour postprandial sugar should be less than 180. And the American College of Endocrinology, they emphasize that it should be less than 140. 2 hours should be less than 140. So to target the postprandial sugars, it's better said, but to make it in practice is very difficult. Why? The major difference is we have to know the physiology, because the endogenous insulin that is produced in our body, it's released mainly into the portal circulation. So it has effective regression or reduction of the endogenous glucose production from the liver. And it also, the endogenous glucose, it suppresses the glucose production from the liver and helps the glucose to be uptaken by the muscles and the fat. But the exogenous insulin that we are giving, it actually, we are giving it into systemic circulation, so there will be under or less suppression of the endogenous glucose production from the liver. So already there can be some amount of hyperglycemia. So we need innovations in the insulin to meet the postprandial glycemic control. Without these two great personalities, Mr. Frederick Banting and Charles Best in 1921, we would not be able to use the insulin nowadays. And this is the paradigm shift after the invention of insulin, because it's a life-saving drug in type 1 diabetes. This is the first child to receive, Frederick Leonard Thompson. We can clearly see that once we started the insulin, the child changes from the catabolic state to the anabolic state. And we have the milestones in development since then. We have the earlier animal insulins, bovine insulins, purified animal insulins, human insulins, and now this is the era of analog insulins. And coming to the insulin administration, we should know two basic things. One is the basal insulin and the other is the bolus insulin. What is the basal insulin? It's the insulin that keeps the blood sugar steady between the meals. That is working throughout the day, 24 hours a day, to keep your blood sugars within normal. And coming to the bolus insulin, which is the insulin that usually the body produced to get control of the prandial sugars or to get the postprandial sugars under control. So if you're taking meal, there will be a spike of insulin production from the body to control the prandial sugars. And when we are giving insulins, we need correction bolus also often to correct the variations to bring the blood sugars under control. So the basal and bolus, we can see that the basal insulin is steady throughout the day and night, while the bolus, it is given in spikes, mainly to cover the meals or the postprandial sugars. And coming to the type of insulins, we have the older insulins, the short-acting and the intermediate-acting insulin. We have been very much familiar with the short-acting that is available in the market. That is, can be usually available as R or insulin R or insulin R. While the intermediate-acting insulin, it is N insulin, usually green color-coded. And the newer insulins are the rapid-acting insulins, especially the Lispro insulin or the aspart from the Novo or the glulysin or Apidra produced by Sanofi. And the long-acting insulins, we have been using or familiar with the newer analog insulins like the Glargine, which is marketed by Lantus as well as the Basalog, or the Detumer insulin that is by the popularly known as the Levemir, and the latest kid in the block is Degludec. And the short-acting insulin, we know it starts slowly. It starts about 30 to 60 minutes. After injection, it reaches the peak in over 2 to 3 hours. It plateaus in over 2 to 3 hours, and then it keeps working for 3 to 6 hours. So it is very slow in its action. It takes some time to plateaus, and then it's wean off. And the rapid-acting analogs available in the markets, these are the common ones that are usually now available in the market. And what happens with the rapid-acting? It's start acting immediately when you inject that. Strongest effect in 30 to 90 minutes. This is the time period where the postprandial sugars are maximum. So we need that much control to control your prandial sugars. And it keeps working 3 to 4 hours. So if we need faster, we have the latest one in the block, that is the FIASP or ultra fast acting insulin. It can be given 2 minutes before a meal to even 20 minutes after a meal. So you can even, in some patients, we cannot decide how much food you are going to take. In such type of patients, you can try with the FIASP. And this is a graph which compares the regular insulin that was available in the market for a quite long period, then the rapid acting and ultra fast acting. We can see that the regular human insulin, if it is like a Maruti 800, the rapid acting insulin, it can be compared to a Honda or a Hyundai. And the ultra fast acting insulin can be compared to a Mercedes-Benz or a BMW, which almost mimics that of a normal physiological human insulin. When you compare the advantages of rapid acting insulin, we know it facilitates more convenient meal time. That is, the convenience or flexibility is the major advantage with the newer analog rapid acting insulins. Offers better postprandial glucose control, and it comes to the baseline or returns to the baseline more early. So there is less chance of postprandial hypoglycemia, as well as we have greater predictability of action. These are the current and emerging prandial insulins to hit the market soon. The regular insulin U100 we have been using. U500 regular human insulin is now in the market. It should be used with the U500 syringe. And we have the other analog insulin, especially the Lispro. They are coming up with the U100, U200, and even the ultra fast-acting Lispro. And you have the Aspart, or the fast-acting Fiasp is now already available. Glulysin is also in the market. And you have the other inhaled insulins that are coming to hit the market soon. And the long-acting insulins, they are peakless insulin. Ideally, it should be peakless. And we have the older one, the NPH insulin, the Lantus insulin, as well as the Detumer insulin. And we'll focus mainly on the last two rows, where they are the latest one in the market, insulin Glargine U300 and the insulin Degludec. These are actually pure peakless insulin, which acts for about 24 hours, more than 24 hours actually, up to 36 to 42 hours. So it's very convenient to give. You can give it once a daily, truly once a daily, peakless insulin. And the advantages of basal analog insulins over the older N insulin is that it is longer acting, purely peakless, less day-to-day variability, and there is flatter time action profile with less peak in activity. So the major advantage is the hypos are very less. You will not get much of nocturnal or daytime hypoglycemias. If the hypos are less, definitely the weight gain is also less. So insulin in type 1 and type 2 diabetes, what is the major difference? In type 1 diabetes, we know the drug of choice is insulin, insulin, and insulin. It should be given either as a basal bolus therapy or multiple dose, or you can go in with the continuous infusion pumps. But ultimately, we have to resort to the multiple daily basal bolus regime to get control over the type 1 diabetics. But in type 2 diabetes, it's actually our preference, the patient preference or the doctor's preference to start with insulin. Not all patients will require insulin at the start of diabetes. Coming to the barriers and challenges to insulin therapy, the major barrier is from the patient side. They will say that, doctor, please give me one more chance, I will get my sugars under control. Or we'll take it after the next time, or they will be afraid of the weight gain. There are more complexities of regime. I may fall into hypoglycemia. I'm very fearful of using insulin. So we have to overcome that patient barrier, and we have to prime the patient that they should have insulin at least any time during their time in diabetes. So better the early the better. And the clinician barriers are also another problem, because we don't have time to explain the insulin, how to give the insulin, how much hypoglycemia, or how much level you have to maintain, the complexities of regime, fear of hypoglycemia, especially in elderly patients, where there will not be much persons to care for. And the pen delivery of insulin is one of the simplest method we can start with, which is very convenient. It's flexibility in schedule, and we have the latest analog insulins which are usually available in pens. And to give the insulin, we should know the key concepts of type 2 diabetes. We know once the diabetes is diagnosed, or the pre-diabetic stage, the beta cell starts decline in their function. So ultimately, we have to preserve the beta cells. So it will contribute to the basal as well as the bolus hyperglycemia. So we have to address both the basal hyperglycemia as well as the bolus or prandial hyperglycemias to control your diabetic patients. The ADA and American College of Endocrinology guidelines, HbA1c target may be slightly different, less than 7 or 6.5, or the fasting sugar between 80 to 130, or postprandial less than 180. But do we go for this in each and every patient? That is a question. No, definitely no, because the ADA and ESD position statement, they emphasize that depending on your patient profile, if it's a short duration diabetes, or if the patient is very young, without any comorbidities, without any risk factors, then definitely you have to be more aggressive in getting the glycemic control, getting the targets to HbA1c less than 7 or 6.5. But if the patient is very elderly patient with so much of comorbidities like a renal failure or liver failure, or chance of hypoglycemia is there, then we should be more relaxed in getting the glycemic control. So when to start insulin type 2 diabetes? Especially if the patient comes to you with a diabetic emergency, like a DK or hyperosmolar ketotic state, non-ketotic state, definitely the drug of choice is insulin. Or if the patient is in a critical situation, like a patient with a stroke or a coronary artery heart disease, or patients with sepsis or even pregnancy, then insulin is a better option. And when the other oral hypoglycemic agent fails, none works, then insulin is the only choice. Or you can even suggest the patients to start with the insulin if they need flexibility. The guidelines for starting the insulin, most of the governing bodies suggest that easiest way is to start with basal insulin. So if the A1C is less than 8, you can start with 0.1 to 0.2 units per kg body weight of basal insulin. Either it can be an NPH, or it can be glargine insulin, or it can be a degludec insulin. And if it's more than 8, you can have a slightly higher dose of 0.2 to 0.3 units per kg body weight. And you can ask the patient to titrate. If the fasting is not getting controlled, that means if it is not less than 130 or 140, you can increase the total daily dose of basal insulin by 2 to 3 units. Taking into account it has to be increased every 2 days or every 3rd day. You have to increase the dose till the fasting sugars reach the target of less than 130. Because your idea with the basal insulin is to fix the fasting first. But the major problem is you will not get adequate HbA1c control even after starting with this glargine or the NPH insulin in about 50% of patients. So we need other options also. Let me explain with the case scenario of Mr. George, who is a 56-year-old male who has been using glargine U100 with a fasting almost a target of 130 to 145, but his HbA1c is slightly higher, 7.8, and he has night sweats indicating the presence of hypoglycemia. He is currently on glargine U100, 65 units per day. So what considerations do you have? If you aggressively go for the basal dose titration, the problem is you may land up in hypoglycemia. And this is a curve which shows that the chance of hypoglycemia is more if you aggressively uptitrate the basal insulin. But the HbA1c level, if you look that there is only minor change. If you uptitrate from 7.6 to 7.3, you can bring by uptitrating the basal insulin. But the problem is you may land up in hypoglycemia. So this is the stage where you have to think of a prandial insulin. If the individual is not meeting glycemic targets on basal insulin, for example, if HbA1c is still not at goal, even after you have started with 0.5 units per kg of a basal insulin. For example, a 60-year-old person, 60 kg person, if you have used 30 units of glargine or the NPH insulin, you haven't hit the target, then it is better to go in for a prandial add-on to prevent a hypoglycemia as well as to reach the target. You can go maximally up to 1 unit per kg body weight of daily basal insulin, but beyond that, the chance of hypoglycemia is there, and chance of your target HbA1c is very less. And the second one is your HbA1c is still elevated, but you have attained the fasting sugars to normal. Then also you have to think of adding a prandial insulin. And the other one is your fasting is controlled, but your postprandial sugars are very high. Definitely you need a prandial insulin. And the other consideration is if you further increase the basal insulin, the chance of getting hypoglycemia is more. We have various options for intensifying basal insulin. You have the oral agents as well as prandial insulins. So we have a lot of data to suggest that prandial control is required to prevent the complications, especially the cardiovascular mortality. So this is the therapeutic diagram given by the ADA, which shows that if your HbA1c is not controlled with a basal insulin, you can start with adding one rapid-acting insulin, either an analog or a regular insulin, before the major meals. And if still it is not controlled, you can go in for 2 prandial insulins. If still not controlled, you have to go in for a basal bolus regime. And other option is you can consider the GLP-1 analog also, along with a basal insulin to get your HbA1c under control. And the other one is you can opt for a premixed insulin. That is a commonly used insulin nowadays. You can go with the premixed insulin. We can give it twice a day. They have recommended even you can give it thrice a day, but ideally, if you're giving it thrice a day, the chance of hypoglycemia will be there. So basal plus regime, that is a along with the basal insulin, you are giving a short-acting or analog insulin before the major meals. You can start with a 0.1 unit per kg body weight before the major meals, and your aim is to have a 2-hour postprandial sugar less than 140. And basal plus, you can advance to 2 rapid-acting analog before the major meals, or even you can go in for the basal bolus regime. If still not controlled, you have to give it a basal bolus regime. In basal bolus regime, 50% should be basal and 50% bolus should be cut into 3. And adding prandial insulins to basal therapy further improves the HbA1c. And the role for premix, definitely premix, you have both the short as well as long-acting insulin, the same insulin, that is the advantage. But the major problem is it is not physiologic. You cannot change the ratio of the insulin in a premixed insulin. So the chance of hypo as well as hyper is there, and you have to often accept a higher HbA1c level of around 7.5 to 8. So this is the complex slide, but only thing I have to say is if you are using a basal plus regime or a basal bolus regime, the flexibility is more. In a hospitalized patient with uncontrolled sugars, if you opt to a basal bolus regime, definitely you can get your glycemic control a little bit early compared to using a premix. So quality of life definitely improves in type 2 diabetes with intensification of insulin therapy. These are the emerging newer treatment options. The insulin glargine U300 and degludec, or the faster acting aspart, or the biochaperone lispro. Also you have the co-formulations like idaglira or iglar lixi. They are all coming to hit the market soon. They are combinations of GLP-1 analog with the basal insulins. So to summarize, all type 1 and many of the type 2 diabetic patients require insulin for the glycemic control. Whether it is the second add-on after metformin, whether it is an injectable drug, it's a basal insulin or a GLP-1 analog, that you can decide. Better you go for a patient-centric approach. Insulin analog insulins definitely fare far over the regular human insulins because it's very quick in its action, and chance of hypo is less, and chance of weight gain is also less. And once you have fixed your fasting, your idea is to check for the A1C. If it is elevated, you have to address the postprandial sugars. You have multiple options for addressing the postprandial sugars, but ultimately many patients will require the prandial sugars for controlling the postprandial sugars. So using separate basal and bolus is easier to control, but premix is convenient. So always think like a pancreas and don't delay insulin initiation. That is the agenda given by the ADA and EASD. Thank you.
Thank you, Dr. Deepak. You had a very nice talk. I think that even after this talk, so many doubts are remaining in our mind. So open to the audience for clearing their doubts and more questions to Dr. Deepak. So open to the dais for questions.
Thank you very much, Dr. Deepak. Thank you for your patient hearing. Thank you, sir.
I got one doubt. You told about starting insulin. In the peripheries, normally don't do SBNC frequently, but when to start insulin? If a patient comes with a fasting blood sugar of 140 or a PPV is or around 200, okay, without examining HbA1c, when to start insulin?
If the fasting sugars are very high, say for more than 200, or if the patient is having symptoms of weight loss, or the patient is already having complications like your creatinine is very high or having the complications, definitely it is time that you should start on insulin. And the fasting insulin, if it is going very high, it indicates that you need actually a basal insulin or insulin to get control over that. And ideally you have to look for the HbA1c, but if it is not available, if the patient comes to you with a newly diagnosed patient with a fasting sugar more than 200, you can suggest them that it is better that you go with a insulin, because there are studies to support that starting insulin early can even have some effect in going in for remission of type 2 diabetes. If you aggressively treat early, in the earliest stages of type 2 diabetes, the chance of remission is there.
Okay, thank you, Dr. Deepak. I think this is over. Thank you all.
Laughter is the best medicine. Unless you're a diabetic, then insulin comes pretty high on the list. These are the words of Jasper Carrot, the famous American stand-up comedian. With a myriad of insulin options within each class, the treatment decision making often gets complicated for physicians. Thank you, sir, for the disentangling talk, shedding a guiding light to the vast topic that is insulin. We invite Dr. John Peter to present a token of appreciation to Dr. Deepak D. We invite Dr. Deslin Salam, physician, GH Pathanamthitta, to present a token of gratitude to our chairs, Dr. John Peter and Dr. Manimaran.
Thank you.